I'd like to invite up our palliative care discussion presenters. I have Dr. Lori Spoozak. You guys can come on up. One of our gynecologic oncologists and palliative care physicians. I have Dr. Meagan Dwyer, one of our oncopsychologists. And then I have Amy Valsequez, one of our nurse navigators from Gynecologic Oncology, all representing the University of Kansas Cancer Center.
Thank you so much for inviting us. This is the first time I've spoken in front of humans in 3 years. It's really exciting. You're beautiful humans. Thank you all for hanging out and still being here. Thank you, colleagues. These are some of my greatest supports and friends and colleagues to work with. So we're so excited to talk today about our favorite topic, palliative care. Oops, back up one. Well, our outline, I can't back up the slide, but our outline is going to be today that we hope to dispel some myths about palliative care and psychology. We hope that we can educate everyone about when to refer to palliative care and psychology, and thank you for backing up. And also, we want to define primary palliative care versus specialty palliative care to figure out like what do we do in those different settings. So I would love, we don't have microphones that I see, but for everyone to kind of go around and talk to each other, like what is the difference between palliative care versus hospice care? What does everyone think when this all comes up for yourself, for your patients? What's the difference? Everyone's shy. Amy, what do people think when they're coming to our clinic?
They usually think there's a hidden agenda, that I have something that they don't know that I was told not to tell them until they got there, why they were coming.
Yeah, people think that they're coming to see us because they're dying. And I love this cartoon. Basically, like this is the feeling. People are walking in and a little bit confrontational, a little bit terrified. Sometimes people have no idea why they're showing up, but really a lot of times people think that they're showing up because they're dying. And we want to flip that story on its head because the current definition of palliative care is really different than where it started. Palliative care grew out of the modern hospice movement that started in the 60s, but what we've learned is that those hospice skill sets that were cultivated actually can be applied way earlier in the disease trajectory and have a huge benefit to our patients way earlier in the life cycle of their serious illness. So the Center to Advance Palliative Care came up with this current definition of palliative care. It's a specialized medical care for people living with serious illness rather than dying from it. It focuses on providing relief of the symptoms and stress of a serious illness, whatever the diagnosis, and the goal is to improve quality of life for both the patient and family. Palliative care is provided by a team of nurses, doctors, social workers, chaplains, and we work together with that patient's other doctors to provide an extra layer of support, and it's appropriate at any age and at any stage in a serious illness and can be provided along with curative intent. And this is way different than what most people think about palliative care. Do you guys agree?
Yeah.
Yeah.
I think a lot of people with palliative care, you know, it's gone on it, like Dr. Spoozak said, we've flipped it, right? The medical advancements are so enormous. People are living with terminal cancer for years, and they're needing help earlier to control those symptoms because they're just, you know, there's more treatment, more symptoms, right?
Right, absolutely. Yeah. And I think, you know, we have a lot of parallels in psychology as well about not sort of knowing when to refer. So I think we struggle, like when should we refer to palliative care? And this is this, you know, the WHO created this diagram and now it's been like changed and modified and upgraded over time. And the lumpy, bumpy path of disease-directed therapy is sort of getting longer and longer and longer as we approach hospice care. Amy, I think, you know, a lot of us take care of patients with serious illness that could be eligible for palliative care, either inpatient or outpatient earlier in their disease.
I think what happens is it's called, you know, we'll get consults and I call it race to the chase. You know, we're literally chasing their symptoms, trying to control them. if it's a late referral and we really can't get to know them before we talk about goals of care and end of life, because we're chasing their symptoms so much that that's all we're focused on, and then we flip into hospice, and then that whole goals of care, and then you don't know what drives the patient's nausea. Is it anxiety? Is it depression? Do they need to see Dr. Dwyer? But all of those things aren't able to be done unless we see them earlier.
So we really want to kind of think about that. How can we get people earlier? And we think about triggers. Psychology has a lot of great triggers. Can you talk to us a little bit about that, Dr. Dwyer?
Yes, so as the slides are showing, we know at least 30 to 40% of our cancer patients are going to experience some kind of emotional distress or psychological problem along the course of their treatment. And that's the ones that are willing to take surveys and admit that. I would guess this is more like 60 to 70% of our patients, right? Because there's all the people who turned it down or are scared of the word psych. This is why in our program we use the term onco-psychology. Oncology is what brings you to me, not the other way around. And whenever we were first meeting with patients and they heard Psycho-Oncology, they're like, psycho? I don't want to go to that kind of thing, and I didn't want to be called that kind of thing. And so, but I think there are things, when possible, we want to utilize the tools that are out there. They've been validated. But also, I think when we get to know our patients, we get to see what's going on with them. And you can kind of start to see, is this different for this patient? Are they responding to my first set of skills? Because all of you, one of our other colleagues in palliative medicine, Dr. Sinclair, will sometimes say, like, I have a sidewalk version of this. And if I try that and I try to encourage the patient to engage in some things, I try to offer a medication, and that first thing doesn't work, then it probably is time to kind of think about that.
Yeah.
I think the next slide maybe tells a little
actually,
more. Oh, is it later on? Sorry, I got them out of order.
Yeah, but this is actually a great segue into primary palliative care versus specialty palliative care. And actually, so I like to think about it as an oncologist, when I'm in my oncology hat, I'm an initiator. So I need to be really good, if I'm taking care of patients with serious illness at primary palliative care skill sets. So the basic management of pain and symptoms, the basic management of depression and anxiety, or discussions about prognosis and goals of care. But when things start getting complicated, so I start an initial pain management, and then I need to start adding long-acting meds, or they're refractory to an initial treatment, then I need to phone a friend to help me. And I think that this is very true for psychology as well, that I need an extra layer of support as a provider, because number one, maybe my skill sets are not there. Number two, I don't have the time. Number three, I don't have the resources. And so this is where I want us to think about, while we don't have a clear clinical trigger, my trigger is myself. And I'll share that I also refer out my own oncology patients to other palliative care doctors, because many times our patients show up to oncology care and they present their best selves. They present their church, outfit, lipstick, their best selves. And when they come to palliative care, they present their most revealed self. And that's where we can actually do a lot of the work that we need to do to support our patients and symptoms, because in palliative care, I'm not the gatekeeper to further treatment. And so that's where it's it's a big deal to be able to refer to another provider.
And they report to me that they're terrified to tell you that if I tell them how bad I'm feeling, they'll stop.
Yes.
And I don't want them to stop.
Yes. And
So they don't want to tell you that.
Totally.
Right.
So
They'll tell me.
I agree. And so I think it's a conflict of interest for me to see my own patients as palliative care patients. So another bright line is when patients are too late for outpatient palliative care. And actually, we need to consider hospice. So we have some clear pictures of patients that we don't need a CT scan or a lab result if we know they have a serious illness that's advanced, where we know a patient has a prognosis of weeks to months of life. And we see common things: severely decreased energy, severely diminished appetite, difficulty walking, dressing or bathing, and having a hard time getting to appointments. this is when it's actually too late for palliative care. And actually, we need to consider a hospice plan of care. So I want us to sort of talk about that, especially for our nurses, because they're doing, like, I would say 50% of our, or so of consults need to be counseled by you.
Yeah.
And almost like go directly to hospice because some of the consults
about
are too
50%.
late. Yeah.
So it kind of, can you go back to the first slide, Dr. Spoozak?
To the, I don't know if I can.
Okay, well,
yeah.
so kind of what I wanted to say too,
Yeah.
with the other slide with you, Dr. Dwyer, is, you know, you taught us that patients will say, am I crazy? Is that why you're sending me to see Dr. Dwyer? And she taught us that the situation is crazy, right?
Normal people, crazy situation.
Right, and that's really good verbiage, and we use it a lot. It's been really helpful because patients are so scared, yet they came to see us and they were scared, and now we're sending them to someone else to be more scared to talk about things. So I just wanted to add that in.
Yeah.
Oh yeah, and then when I send the patients who come to me and I start seeing all of these other symptoms that they're hiding from their physicians, right, from their oncology teams, and I say, you guys should talk to the palliative care team. Is it that bad?
Yeah.
Well,
Yeah.
A, I'm not qualified to tell you that, but usually I try to say no, and this is a way I describe a lot of this to patients. You know, I 100%, I don't like to do the raise the hand, but you guys can nod along or show some sign of, if I said, at your core, this is a goal that you have for yourself, everyone in the room is gonna nod their head, right? We wanna live as well as we can for as long as we can. As well as we can for as long as we can. Your oncology team is in charge of the as long as you can piece. You guys are the medical side and I'm the emotional side of as well as you can. And the sooner we get as well as you can in line, the better your life's gonna be, regardless of what they're able to do with the science they have. We gotta back up.
And then we're going to meet the patient where they're at.
Yes.
So meet them exactly where they're at. You know, one of the hardest things as a palliative care clinician, nurse, doctor is I think when you, in your core, disagree with the decision they're making. You disagree with they want to be intubated. It feels bad in your soul, but we have to meet the patients where they are and support their goals. You know, I think being a treatment nurse, a triage nurse, a CNC for many of my oncology years, I think when your nurse is calling you 100 million times, doctors, and you're like, wow, this patient is keeping me busy, ding, ding, that's time to send them to us because our patient load is like a third of what you guys have. So that way we can hopefully hone in on those symptoms a little bit more.
With that said, though, I'll just say, just anecdotally, in our practice, it's growing so much that actually it's a wait of at least a month. So if someone's in true crisis or dying, they may not be seen in the outpatient palliative care clinic. So these are some, you know, we try and have some bright lines. So what are some other bright lines for psychology referrals?
So cues to let you know. So if the patient presents notably different, if you've gotten to know your patient and the Sunday version of them doesn't show up to an appointment, right? They look like they just rolled out of bed, and that's abnormal for them, right? They talk about being, you know, exhausted, their families saying they're sleeping a lot, they're tearful, they get really irritated, especially for our male patients. I know we're talking about taking care of a lot of women here, but you know, the fastest outlet for emotion for a lot of guys is they're taught it's okay to be grouchy, it's okay to be angry, but you can't be sad. Right, so if a guy is getting a little more irritable, or women, we get irritable too, but those kinds of things, they're not engaged or interested in doing normal activities. If the grandkids come and they don't want to get up, please call me immediately. Like, please call someone. Like, that is a big, I could aspire to be the best therapist ever walk the planet. I will never be as good as time with your grandchildren. So anytime a patient says, my grandkids are coming into town, I say, cancel our appointment, I'll see you later, have a great time. Because I know they're gonna do better with that, right? So that's really important. And how do you feel when you leave the room? If you walk out of the room feeling like you just took 9 shots of espresso and you need to do some deep breathing, your patient is anxious. and you empathically felt it, right? And you felt it in your core, like, oh my gosh. Imagine walking around with that feeling all the time. If you walk out of that room and you feel like you have to drag your feet and you're exhausted, your patient is depressed, and you empathically felt that. And good that you're feeling that. But that's a big, or you you leave the room and you feel really angry. You're like, okay, we are not handling this well. You guys you have good barometers.
Right.
Listen to them.
And so we have to like figure that out and just, hone in on those triggers for ourselves. So we wanted to quickly talk about this. So if palliative care is not just death and dying, what do we actually do? What's the secret in the sauce in clinic? Because I think a lot of people actually don't know what we do in a visit. So this Grim Reaper is flipped on his head. He's chillaxed, okay? All right, in his tie-dye. This is actually, I would say the majority of our visits are spent in laughing. I mean, we thrive in focusing on, after we've put out the fire of whatever crisis people are showing up with, that we're talking about life coaching, we're talking about joy, we're talking about trying to figure out the ways that we might optimize that life. And so we kind of live in these supportive care assessments. We talk to our patients and say, your oncologist is going to focus on that cancer-directed care, and in palliative care, and actually in psychology as well, I think there's a lot of overlap that we're going to take off everyone's plate all these other domains of care, and we're going to explore those, and we're going to work on those in ways with more time and different skill sets, and also send out even more referrals to optimize all of these other domains of care. What do you think of that?
I think one of the big things that when we get an early referral to palliative care, sometimes the physicians don't even prescribe a medicine. It's really figuring out who they are, what they're made of, what their family unit's made of, and making sure that we're hitting on all of that stuff just a little bit. But that's a good early palliative care referral.
Absolutely.
Don't you think?
The other thing that I love is actually patients can graduate from palliative care. This is actually one of my favorite things, is when I've seen them early enough in their illness, I put out the fire, we're hanging out, we're optimizing life, we space out visits, and then at one point they can actually graduate from palliative care clinic because they're doing very well. We're always here, we're always a place to come back to, but there is a time when they can graduate.
We call those well baby checkups.
Yes.
Like we see them like every 3 months.
They're the best,
So let's walk through some cases together. And I hope that we can all be interactive in these and think about, when should we refer to palliative care? When should we refer to psychology? And also, when should we refer to hospice? When should we not PESCO and collect, $200? So our first case is a 70-year-old with stage 4 ovarian cancer undergoing adjuvant chemotherapy. She's status post cycle 2 of carbotaxol, and she's rapidly worsening neuropathy, refractory to dose reduction and initiating duloxetine. What do you think? Who should we refer to and why? Palliative? All right, why? The symptom management. What is it about these symptoms, though, that are like your trigger? They're going to be your trigger going forward. The quality of life, they're refractory, I heard. Yeah, so when things start getting complicated, refer, so that we can get on top of them. The sooner, the better. What do you guys think?
I think whenever you're having to dose reduce something is a good, time to kind of reach out and see, is there something that we can do to make them feel better so they can get all of their chemo and not just the reduction part of it too.
Absolutely. I think like an aspirational future is thinking about palliative care, especially in combination with clinical trials, and thinking about how a lot of our new therapies are life extenders, but not necessarily cures, is like thinking about how we use palliative care to get people through treatment and to keep them on clinical trials, and that that palliative care can grow in oncology care, especially in the outpatient clinic, to keep people living as well as possible and to keep them on therapy, which has sort of like not been conceptualized for palliative care before. Yeah.
Something I talk with patients, because I feel like sometimes I'm in that interim space where maybe the medical team is talking about this. The patient is coming to me saying like, yeah, the neuropathy is just getting so bad. I don't know if I can keep going on this. There's this awful word we use, but I haven't figured out a better word, and I'm not blaming you guys. No one in this room decided to use the word tolerate, which when patients can't tolerate something, they feel like you're saying they're weak, right? You can't tolerate it. You can't cut it, right? I don't know what that better word is. Anyone, millions of dollars for you if you can come up with a better word, because I would love to hear that. I don't have them to give, but we'll find it somewhere. So I tell the patients sometimes, the oncology team, they're like your military. They're going after the enemy, right? And palliative care is like the Red Cross coming behind, making sure you have what you need to keep living in this crazy environment that's getting all torn up. And I feel like sometimes that clicks, like, oh, so they'll help me, but I don't have to stop fighting the cancer. No, not at all. Actually, we want to help you do that. We want to support you in that.
And we'll say that, you know, we're here to help you feel better so you can have more chemo, so you can get the dose you should be getting.
Absolutely. All right, so we have our next case is a 45-year-old with recurrent metastatic hormone-positive breast cancer with worsening back pain from spinal mets and difficulty coping with her recurrence. Who should we refer to? Both. I agree. Why? Treat the back, treat the back pain. But also, so there's this concept, actually, Dame Cicely Saunders, who's the founder of the modern hospice movement and palliative care in its current iteration, talks about a concept called total pain. And that pain actually is not just here, it's also here, it's here, you know, in order to treat pain, we have to treat all of those domains of care. And so that is why many times patients will really need an exploration and support in all of those domains to actually feel better. You know, what's so fascinating is even if their disease is responding to treatment, if something is misaligned in one of those other domains of care, they still might not feel better. And so this is where our overlap is so powerful.
I think it's that concept of looking at and helping people through pain and suffering, which is like how we deal with, emotionally cope with the physical pain that we're dealing with. And with this case, and I think it was on the other slide and I didn't hit that point, is this is going to be life-altering potentially, right? And how she gets around the world, if she has to be wheelchair-bound, if she has to use a walker now, or anything like that. So that's always it would be hard for any one of us to make those kinds of adjustments. And so having someone to walk alongside, help them cope with, and set realistic and fair expectations for themselves and their families, I think is really important, and is definitely something that's right up the alleyway of therapists and psychologists. So.
The other thing that I think is really critical is this is someone who's going to be living probably a really long time with cancer. How do you cope with scanxiety? How do you cope like living scan to scan? How do you talk yourself down from being afraid of dying at every time you have to show up at your oncologist office? These are the things that we work on all the time together. So
being afraid to make plans.
Yes, being afraid to make plans. What are you doing to celebrate yourself, regardless of what your scan says, for all the work you've done in between treatment? Are you making a plan for dinner? Are you going on a trip with your spouse?
Buying insurance for the trip.
Right. What are you doing to celebrate yourself, regardless of what your disease is doing or your scan says? So we work sort of long term on that type of life coaching, so that it tries to allow folks to get skills to address all of the changes that they're facing over such a long period of time. We're living in this time of totally uncertain prognosis for our patients. It is a wild time to deliver cancer care. It used to be cure or dead. And now people are living in this murky, ambiguous space where we can't tell them how much time and when. It's treatment to treatment. And so how do you cope with that psychologically? That is not something that's in the public dialogue about cancer care, right? And the cancer experience. So we're here to help with people coping with that reality, you know? And I think it's actually our biggest growing population of patients, is figuring out how to, psychologically cope with living with cancer. Yeah. All right. Our last case, a 30-year-old with recurrent metastatic cervical cancer whose status post-chemo RT, immunotherapy with progressive disease. She's having difficulty ambulating and performing self-care. She's having severe pain refractory to as-needed opioids. She's having difficulty eating and hydrating. She's extremely tearful at her visit, begging for further treatment.
She probably needs hospice.
She probably needs hospice.
It might be helpful to put her in palliative care and then help her.
So I love hearing more. Yeah, tell me more. It also, oh God, 30. Ugh, doesn't that just make your heart feel so bad, right?
I agree. As the oncologist, when they're demanding treatment, he's saying, oh, well, no, I'm going to refer you to hospice. You don't get palliative care. It's a
Right.
very difficult discussion when I am the treatment provider.
It is
They don't
really.
believe me.
Yes,
with
it is so hard to disentangle the thing that has been keeping you living longer. This chemo has been keeping you living longer this whole time, and your affiliation with it is more life, better life. And to try and tell someone and be able to disentangle that, to say, actually, for how you are functioning right now, more chemo means less life, worse life. Being able to have that conversation is so hard.
Yeah.
So, this is a really tricky case.
I think that these are the patients that we'll get sometimes, and the first thing I'll ask is, I kind of want to open it up because I want to know what their oncologist said. Like, what has your oncologist told you? And this can be a 5-minute conversation on the phone, meeting them for the first time to schedule an appointment, or it could be an hour. In that hour, I've really listened to the symptoms, but also the scared and the goals of care and possible end of life. And they've been terminal for, let's say she's been terminal for 5 years. Well, they've always had something up their sleeve. They've always had something to give them. So it's hard for them to know that there's nothing else you can give. There's nothing, really? So trying to just hear them and give them a safe space to really talk about it, I think is what I do with those patients when I get them. And try to get them to see them earlier. But I think that initial nurse visit is really helpful for us to find out what we need to do.
And what Amy's talking about is the phone call. The nurse visit is the phone call and checking in. Many of our consults actually don't end up seeing us because they need to be directly referred to a hospice plan of care. Basically, they're progressing so quickly that they would never get to the palliative care visit.
And sometimes what I'll do is, if the patient's really kind of opened up, and I'll reach out to the oncologist and say, this is what they're thinking. They're going to take a couple days, and they might call me back Monday and want hospice. But there's been multiple phone calls in between there.
And it is that shift from, are we treating you to help you live, or are you now in a state of living to take the next treatment? And that's something I try to talk with patients when we can get them upstream and help them see the difference. But
I love that.
I don't envy you all for that decision.
Yeah, I think we've run out of time. So there is a question here. Should I answer it? Okay, so any tips to convince a patient they need to be seen by palliative services that don't want to be seen? I think actually what's so fascinating is actually most patients don't know what palliative care is, and it's in fact the provider that has a bias. And so explore. So tell me what you know about palliative care. What have you heard? well, I've heard that it's for dying people. Well, I want to tell you that you are not dying. But I really think that they could help, and they could help me too, take care of your whatever symptom, your nausea. But really exploring what's that bias, where is it coming from? Is it from the patient? Is it from the family? Or is it actually from the provider themselves? Because like we've talked about, palliative care has gone from from hospice to inpatient palliative care to outpatient palliative care, and it keeps expanding. And so what people know of palliative care may be from 20 years ago, and now it's something totally different as we're moving it further and further up front. So it's really exploring that with people is my best advice.
I think the other thing that really helps too is letting them know that, oh, sorry.
Yeah.
I think the other thing that really helps too is letting them know that the biggest pushback I get is I don't want to see another doctor. I don't want to see another person.
Yes.
And if you explain to them, well, talk to them about where your goals are and what your needs are.
Yes.
And if they can help you, they may only need to see you once every 3 months, or it's not somebody you're going to have to see necessarily every single time, but they can help us with your goals at home and your care at home. And they can even help your caregiver because they'll look at the whole picture. And I think
love
that really
that.
helps.
And I think sometimes too, if the oncologist is really for it, but the patient just won't do it, call one of us nurses, and they're going to be here next Wednesday at 4 o'clock. Can you come meet them with me so they're not so scared of you? So they see I'm with the physician, I'm on the same team.
Yeah.
So I think
Try to help them be curious. I think that's one of the best things that came out of Ted Lasso, aside from many, many things, right? Is the be curious, not judgmental.
Yeah.
I've been saying this for years. Darn it, Jason Sudeikis is making money off of it now, right? It's like when patients are complaining, I wonder if the palliative care team, they're kind of like this symptom management specialty. I wonder if they could really help with that neuropathy a little more. Would you consider talking to them? Even just a consult to see what they have to offer.
I love it.
No one that has ever gone for a consult has come back to me and been like, that was crap, I'm not doing that. No, so I think sometimes it's just gently, I wonder if they could help. I wonder if it'd be worth having one appointment with them. You don't have to commit to doing it all.
Yeah.
And I appreciate when you say that about psychology. I wonder if Dr. Dwyer's team could help with how anxious you've been feeling or how your sleep's been bad.
I love it.
All right, thank you, ladies.
Thank you,
That was
guys.
fantastic.